So Ronnie had asked me, and I appreciate her doing this, to share with you a project that we undertook to examine two conditions, short chain acyl-CoA dehydrogenase deficiency and isobutyryl-CoA dehydrogenase deficiency, and to see if we could get better information about whether or not we really need to screen for these disorders in Georgia. So I'm going to give you a little bit of a history about how these even got on newborn screening, a little bit of history of newborn screening, and then some of the studies that have been done by other groups in other states. And then we'll talk about the study that we had done with the genetic counselor that was recently published, and how we actually did succeed in removing these two conditions, I will say, from the Georgia newborn screen. So that's the end of the story. So if you want to go have lunch, you can. But at any rate, for those of you who want to still listen, we'll go on from here. So these are our objectives, which I just talked briefly about. So newborn screening. Everyone is familiar with newborn screening. It's a public health program, and it involves education. It involves screening, follow-up, both short and long-term. And long-term, I think, has been something that we're grappling with, and at least in Georgia, we're trying to develop a much better long-term follow-up program, because this is important, as you will see. Evaluation, diagnosis, and management, at least in the immediate newborn period, one could argue that's part of newborn screening. And again, as everybody knows, it all started with PKU, 1934. And I got this wonderful slide from Melissa Wasserstein, who just gave us a talk, grand rounds, a wonderful grand rounds on Monday, about the expansion of newborn screening, how we keep adding disorders. So this talk is a little different because I'm going to talk about removing disorders. So we know in 1934, Foling had made the initial description of PKU, and that Jervis et al. Found that there were many patients with, then it was called mental deficiencies, that in fact did have PKU. And then Bickel figured out that you could actually treat it. And then the man who I think a lot of us consider the father of newborn screening is Robert Guthrie, with the development of the bacterial inhibition assay to be used to screen for PKU. And I think we all know that we now screen for a lot more disorders, and it seems as if we're always adding new disorders, which is a good thing, because it means we now have better treatments and we understand the natural history better. So let's talk about these conditions, SCADD and IBDD, and how did they get on the newborn screen. And so SCADD, as many of our inborn errors, is a recessive condition caused by pathogenic variants in the ACAD-S gene. And it causes impaired oxidation of short chain fatty acids. And the first description was in 1987. One infant died of a metabolic acidosis, and other reports note hypotonia, seizures. And we identify these patients with an elevated C4 and acylcarnitine profile, and then they typically have elevated levels of ethyl malonic acid in the urine. IBDD, sometimes also called isobutyryl glycinuria, because isobutyryl glycine is found in the urine. This is also a recessive condition, and it has to do with an enzyme in the catabolism of the branch chain amino acid valine. And the gene is ACAD8. And the first report was in 1998. There was failure to thrive, a dilated cardiomyopathy, and profound carnitine deficiency. And carnitine actually was curative for this child. Interestingly, we also see an elevated C4, but what's different from SCADD is that we find isobutyryl glycine in the urine. So why did we start screening for these? And it's all tandem mass spectroscopy's fault. I think that really technology drives a lot of what we do these days in medicine. And tandem mass spectroscopy, the development of this technique where you bombard atoms sort of consecutively, and there's a characteristic pattern, really revolutionized newborn screening. It was a cheap and reliable test, and we could now look at a whole bunch of different disorders with just one diagnostic modality. And so with the development of tandem mass spectroscopy, there were a number of things that occurred in the history of newborn screening, which is really very important. And I take this slide from a good friend of mine, Reed Sutton, at Baylor and Texas Children's. He gave a nice talk on the history of newborn screening at ACMG many years ago. And in 1999, the American Academy of Pediatrics Newborn Screening Task Force recommended that HRSA assist in developing national recognized standards for the process of newborn screening. There really wasn't any national standards. Sort of each state did what they did. And to some extent, that's true today, but we can discuss later. And in 2001, Maternal and Child Health Bureau and HRSA charged the ACMG, the American College of Medical Genetics, and today it's Genomics, to evaluate the scientific and medical information related to screening for specific conditions and to make recommendations. And in 2002, an expert panel of more than 70 stakeholders was convened. And it was really a Herculean job. And in 2006, the ACMG published Newborn Screening Toward a Uniform Screening Panel and System. And this is when the RUSP was developed. And this was adopted by the March of Dimes and endorsed by the Secretary of HHS. And if you look at this paper, which is quite large, from page 12 to 252, what this group did was they used a weighted scoring system where they looked at clinical characteristics, analytical characteristics of the test, diagnosis, follow-up, natural history, treatment. And they were able to come up with a panel of 29 core conditions, which they recommended be on the recommended uniform screening panel. What's interesting is if you look at the RUSP today, there's now 35 disorders. So we continue to add. And what they also found that they recommended that there were 25 secondary target disorders that were conditions that were either part of differential diagnosis of a core condition or part of the process of looking at a complete profile. And these included SCADD and IBDD. What's interesting is if you look at the paper, and I quote, some of the conditions detectable by acyl carnitine profiling may turn out to be benign in a number of cases. And they specifically list SCADD. They did not list IBDD, by the way. Okay, so with the publication of this in 2006, in 2007, Georgia, and I'm sure many other states, began reporting isolated elevated C4 levels, which allow the identification and management of SCADD and IBDD. And it turns out that after many years of newborn screening, you talk with various colleagues, it seems that all cases of SCADD and IBDD are possibly biochemical phenotypes with long-term sequelae. And I think others have hypothesis that severe cases of these disorders probably had a different disease. We don't always have evidence of that, but so what is in the literature which supports that maybe these disorders are simply biochemical phenotypes with no morbidity or mortality? One of the first papers I was able to find was by Weisbrunn et al. From Massachusetts. And they reported on 14 children with SCADD. Now, these children were treated with low-fat diets, frequent feedings, and glucose monitoring. 8 of these 14 were detected by newborn screening, and they said they were all normal. There were 6, I think 3 were from out of state, another 3 were not positive on newborn screening, but they had other clinical symptoms. Some had hypoglycemia, developmental delay, microcephaly, and so they had various diagnostic workups, and they were found to have a SCADD phenotype biochemically, but many of their other findings they found out could be explained by other disorders. In fact, one of these children who had microcephaly and epilepsy wound up having Rett syndrome. And so they specifically say in this paper, and I quote, "These findings suggest that SCADD may be benign, and the clinical symptoms ascribed to SCADD reflective of ascertainment bias, or that early identification and treatment prevented complications that may have occurred due to interaction between genetic susceptibility and other genetic factors or environmental stressors." Now, the California group published a large series of infants, 76 confirmed SCADD cases out of a little over 2.5 million newborns. And they reported the long-term data on 31 of those children. And they were all healthy developmentally. There was no epilepsy, no behavioral disorders. 3 patients did have isolated speech delay. Again, that's not exactly an uncommon thing in children. 2 patients had hypoglycemia in the neonatal period, but they had some good reasons to have neonatal hypoglycemia, which again is not an uncommon clinical finding. And so this group also states, "This study also provides evidence to suggest that even when associated with deleterious mutations, SCADD diagnosed by newborn screening presents largely as a benign condition." Now, not long after that was published, again, this is in 2012, the Illinois group looked at 16 children with SCADD and 8 with isobutyryl-CoA dehydrogenase deficiency. And all of these children were developmentally normal, except 1. And it turns out that 1 happened to have the 22q deletion syndrome. So, interesting. Now, personal communication with one of my colleagues at Michigan, we actually wanted to publish our cases with the Michigan group, but it just didn't work out. And unfortunately, the Michigan group has not published this yet, but they want to. They did a study, and they had 77 cases of SCADD and 13 cases of IBDD, and they are all identified a newborn screen. They are all developmentally normal. And so Michigan has stopped reporting isolated C4. Tricia Hall pointed this manuscript out to me, and if we have a chance, this is a case report that just came out. And it's a child in the Netherlands with isobutyryl IBDD, which they're proposing is associated with autism. I'm not so sure. And this is the problem with case reports, okay? But what this paper did do is review the IBDD cases in the literature. And so I just thought I would present that here before I get into our study. We're good for time. So 47 individuals have been reported with IBDD in the literature, according to this paper. 38 have biallelic variants in the known gene, in the enzyme, the gene for the enzyme. And of those 38, 24 asymptomatic, and 12 showed clinical symptoms. And now, if we look at those clinical symptoms, they're all not terribly specific. Intellectual disability, hypotonia, speech delay, learning disability, failure to thrive. Again, most cases of failure to thrive is you're not taking in enough calories. Congenital heart malformations, which are fairly common, they didn't really say what they were, and a dilated cardiomyopathy. So again, hard to know if these were due to the isobutyryl dehydrogenase deficiency or due to other disorders. Okay, so given all that, it made us wonder, do we really need to follow up on these C4 results? One is, it really does cause parental anxiety. You have a baby, the baby looks fine. Even in children with a well-known metabolic disorder like MCAD, and nobody would debate that, parents are anxious because their baby looks normal. And so when it comes to follow-up for C4, are we really causing, unnecessary anxiety? Are we doing more harm? Are we over-medicalizing these conditions? And what is the cost of follow-up? So we decided to embark on a project with one of our genetic counseling students. One of the wonderful things about having a genetic counseling program is you've got all these eager minds who are looking for a project, and they have a set period of time to get that project done in. And so they're usually highly motivated. And so we wanted to determine the current health status of children diagnosed with SCADD or IBDD through the newborn screening program in Georgia, and compare these to children without a medical diagnosis. We wanted to look at their health status based on phone interviews and or chart review. And we wanted to try to quantitatively measure parental anxiety. Not so easy to do, but there are validated tests, and we tried to do that, but as you will see, it didn't quite work out the way we wanted it to. And so we recently published this paper in Molecular Genetics and Metabolism, and it really did take a village, and I'll talk about all the people who helped later on, but it was important to have the state helping with us, as well as many other key players. So what did we do? We were able to we did a chart review between 2007 and 2016, so almost 10 years. And during that time, 614 infants had an abnormal C4. So that means 614 infants did need some kind of follow-up. There were 52 cases of SCADD and 9 cases of IBDD based on confirmatory biochemical, and occasionally we had molecular data. So we only had molecular data for 16 out of 52 of the SCADs and 5 out of 9 of the IBDDs. And the final diagnosis was based on what the clinician said to the newborn screening program. If the clinician at the time said, this child has SCAD, then we counted that as a case. And then what we did was we developed a health survey, and we tried to target questions for systems that would be important for SCAD and IBDD. And then we tried to use a validated questionnaire to measure parental anxiety called the Pediatric Inventory for Parents. This was developed by a psychologist who's currently at Children's National, and it was developed for parents of children with malignancies, with cancer. So it's a little bit different what it was developed for, and it's kind of labor intensive. And I had the sense that we would not get a good response to it, and we didn't. We only had 6. So we couldn't make any definitive quantitative assessments, but we have some qualitative comments from the parents. When you look at the breakdown between the 2 disorders, really no difference between the sexes, as we would expect. They're autosomal disorders. Interestingly, we had a fairly high percentage of Black children with SCAD, much higher than the population percentage in Georgia. And so that's something we haven't followed up on, but it was just interesting to note. And you can see the age range was between 1 and 10, as you would expect, given the time frame of this study. And this gives you an idea of how many cases we would diagnose each year. You can see pretty much between 3 and 6 cases of SCAD. Actually, many years it was at 6. And then IBDD, 1 or none throughout the study period. Now, before I show you the actual data, it turns out we had 3 groups. We had what we're going to call a phone survey group. So basically, all of these families were invited to partake in this study. And of course, it was IRB approved. And we were really only, Rua, the student, was only able to contact 18 families, 16 with SCAD and 2 with a child with IBDD, and to specifically ask them questions on the phone in addition to chart review. And then we have a chart review only group, where we didn't actually ask mom, oh, okay, Johnny's in the 4th grade and he's doing well, right? So we had to just use the chart. And then for our control group, so it's interesting the way we did this. And we got some counsel from Judy Friedovich-Kyle, as many of you know, studies galactosemia. And Judy has used the CDC listserv parental group as a means of getting a control set of healthy kids. Obviously, there's a bias here. CDC parents are probably going to be a little overzealous to take part in public health studies, but the questionnaire was sent out on the CDC listserv, and we took 75 healthy children between the age of 1 to 12 with the average age of 4 to use that as a healthy cohort to compare some of the things that we asked, and you'll see what I mean in a second. So basically, this is sort of the essence of the study. Are the children developmentally appropriate? And if you look at the phone survey group, all of the SCAD children were, the 2 IBDD ones were. In the chart review group, all of them were fine. Interestingly, in the phone group, only 70 out of 75. So really, this is sort of like one big take-home message, right? All of them are developmentally appropriate. We then tried to dissect out a little bit more, and we asked about emergency department visits. And 3 parents in the telephone group said they took the child to the ER for poor feeding, or the parents thought the kid had a hypoglycemic event. Right? There wasn't actually a documented one. There was one hospitalization due to a hypoglycemic event, and that was an infant sent to the NICU. And you'll see that in the next slide. When we specifically asked about hypoglycemia, it turns out all of these episodes were in the neonatal period. And they were all in the SCAD patients, not in the IBDD. And when we further looked into those, we found that all of those those patients when they were babies had some predisposing condition to neonatal hypoglycemia. So you can see number 59 and 60, there was maternal diabetes. 30 was a premature infant, and 32 was fairly small for gestational age, all predisposing conditions. We tried to ask about cardiac complications, and we only found one. It was interesting, we didn't find anyone in the control group, quite honestly. And this child had an ASD, which I don't think anybody thinks is related to either disorder. We asked about muscle issues, and again, we got sort of a vague cramps and stiffness. And we tried to get at whether or not these kids could have rhabdomyolysis. And basically, there was no reports of like dark urine or cola-colored urine. Now, like I said, we tried to get at parental anxiety using that pediatric inventory for parents. And, you know, you really couldn't make any definitive conclusions. And so what we did was we just took subjective quotations from what the parents told the student over the phone. And you can see I was so worried I thought my son was going to die. I appreciate that the diagnosis made me more aware of potential health problems to look out for, but I feel that the amount of stress I experienced at the beginning was not justified since my child never had any problems. And then what's interesting here is the mother of an asymptomatic 10-year-old male reported that she still follows up with genetics and has continued the riboflavin and L-carnitine, even though probably the new geneticist suggested that the treatment is no longer needed. The mother stated, "I feel that the treatment has been helping him, and I worry that something will happen if he stops taking it." And then lastly, one mother reported that she was concerned about having another child with SCAD and wanted to know more about the recurrence risk and prenatal testing to prevent having another child with SCAD. So, you know, our conclusion was all children with SCAD and IBDD identified at newborn screening in Georgia between 2007 and 2016 had no long-term morbidity or mortality. While we did find a higher incidence of neonatal hypoglycemia, all of those infants had risk factors. And, you know, parents do report feelings of anxiety and concern for the health of their infants. And so if we go back to the literature and we look at all these newborn screening cases, we have the 8 out of 8 identified in Massachusetts for SCAD, the 52 out of 52 in Georgia, the 15 in Illinois, the 77 in Michigan, the 31 in California. That's 183 out of 183 who are healthy. And the same can be said of IBDD. So we decided to propose removing C4 as a primary target from the Georgia newborn screen. Even though it's technically not a primary target, we've been reporting it for a long time. And we'll still use C4 and C5 for screening for GA2. And so I did some polling of my colleagues. I was going to put this on the metabolic listserv, but I did that once for 3MCC, and there was such a long train of responses from around the world. I thought, oh my goodness, I really started a problem. So I just decided to independently email people. And one person says, I do wish they would take it off. For the one IBD case that we have, asymptomatic for now, not warranted, very rarely symptomatic, if ever, not on RUSP. That's actually not true. It is on the RUSP for a secondary target. A newborn screening program does not pay for the follow-up testing needed. That I could believe is true. Another colleague says, yes, we've seen far fewer C4 SCADs. Luckily, as I told you, Michigan no longer reports isolated C4. California, okay, listen up, Steve. I would love if California removed C4, but California is required by state law to screen for any disorder on the RUSP panel. So I think the RUSP would have to remove it before California could make any changes. That might be a better advocacy approach, one I would support. In Kaiser, Northern California, we get about 5 to 10 C4 flags a year, always SCADD or benign ACAD variants, and families are indeed baffled by why we are screening for a disorder and then essentially doing nothing. Texas does report C4, but my colleagues at Baylor, Texas children do not follow the SCADD patients. I will say that I am happy to report we just received a letter from Kathleen Toomey in the Georgia Department of Public Health. I had to take out a couple of other things in this letter that aren't pertinent to this talk, but she writes, in addition, I am in support of the recommendation to remove short-chain acyl-CoA dehydrogenase deficiency and IBDD from the Georgia newborn screening panel, as these conditions represent biochemical phenotypes rather than clinically significant disorders, blah, blah, blah. So, you know, it's kind of taken a village to do this. I think, you know, Rua did an excellent job calling these families and going through the data. Tricia was really fantastic in helping out and being on her thesis committee. And actually, you know, the one thing about these genetic counseling students is if they don't get the paper written before they graduate, they never write it. So you wind up writing the paper. At any rate, we did. And Tricia was really instrumental there. Angela Wittenauer is our nurse coordinator for the newborn screening program. She was also very, very helpful. Elizabeth Bengochea, a GC at Emory at the time, Kevin Park in the School of Public Health, and Renee Moore helped with the statistics. Ronnie helped a lot and provided some financial support for the student, and Art Hager was the coordinator of the Georgia newborn screening of the lab. And so, you know, we think we made the right decision. And one of the good things and the bad things about newborn screening is each state does kind of what it wants. Again, that's a good thing and a bad thing, right? Look at COVID. It's a bad thing, but you know, we are able to remove it where another state may not be able to do that. And so, oh, and this is just if anybody had any other questions. Okay, so anyhow, I'll end there and be happy to open it up to discussion. And there you go.